Welcome to today's webinar, Care Coordination, How the Investment Can Help Your Organization Accomplish the Triple Aim of Healthcare. Before we begin, let's go over a few housekeeping items. If you're on the line and you've not yet connected to the webinar, click the link in your confirmation email. Your browser may prompt you to download and run a file. When you're connected, you should see the presentation on your screen. If you have questions, you can send them via WebEx's chat function. Please take a moment and find the chat bubble icon in the upper right corner. You can type and send questions throughout the presentation. We'll compile them and take time at the end for answers. This webinar is being recorded, and a copy will be made available to all attendees after the event. Now it's time to begin.
Hi everyone, my name is Christine Weishuttle and I am a nurse care manager. I'm currently working for University of Utah Health Plans on the behavioral health team. I've been a nurse for about, let's just say greater than 25 years and have worked in a variety of settings, hospital settings, long-term care settings, home health, worked in the emergency department, cardiac care, and right now I'm doing healthcare insurance.
Good afternoon. My name is Eric Christensen. I currently manage the Integrated Services Program with the Utah Department of Health. We're part of the Maternal and Child Health Bureau. We provide direct care coordination services to children and youth with special health care needs around the state. I've been with the Department of Health now for approximately 18 years. The majority of that time has been spent in clinical settings. We provided clinics around the state in rural areas for a number of years, and I managed the neonatal follow-up program for a number of years. Currently, though, we run the Integrated Services Program, again, which is care coordination services, and soon to be adding clinical services to rural areas in the state, and care coordination services to any child who is determined to be a child with special health care needs.
So as I was thinking about this presentation today, I thought about when I started into care management about 13 years ago. I accepted a position with University of Utah and really didn't know much about care coordination or care management. It was my first time to foray into this field, but over the past 12, 13 years, this has really come to the forefront, which is what brings us here today talking about care coordination. It really is the fundamental means of managing the health of populations, and it's become an integral part of every healthcare system. What we'd like to do before we start is get a sense of who is on the webinar with us today. So we have a quick, let's see if I can get the screen to advance, a polling. If you all don't mind, take your cell phones and log into menti.com and enter the polling code that you see on this screen, and then just let us know what your role is, what you're doing in healthcare, so that we know who's on the call with us today. We'll give you just a moment to do that. So we're hopeful that this will work. We had a technical glitch towards the start of the webinar and had to switch computers. So I'm hoping that this actually will work. I don't know. We're not seeing anything. Maybe if someone could give us some feedback if you're able to enter in any information. I apologize. The code is right there. Let's see if anything's coming up on our screen here. Yeah, it doesn't look like this polling is going to work for us, unfortunately. Darn it, we sure would like to know who we're talking with. We'll just go on. Okay, so The basic concepts of care coordination that I'd like to review with you all today are pretty simple. To provide evidence-based, quality, cost-effective healthcare for the most at risk. And we do this through a system of alerts or reports generated. In the insurance field, we do it through claims data. Anything we can do, any trigger we can use to find those that are most at risk for healthcare. It's a multidisciplinary practice incorporated into various settings throughout the continuum of care. Part of our purpose is to break down barriers. It's really very evident as you get into the care management what people's barriers are, and when you have someone in a hospital setting and discharge them to home, you don't know what that home environment is like. And part of the role of the care coordinator is to find out what barriers there are at home that we can help them to overcome. We would like to empower patients to manage their health care. I think this is very important that patients take an active role in their health care and have input into their health care. We, of course, try to contain costs and efficient use of resources. We want to definitely decrease fragmentation and duplication of efforts. And this early identification is important because we know that 80% of the healthcare dollars come from 20% of the populace, the chronically ill. So really what we're talking about when we talk about care coordination is the triple aim of healthcare. Healthcare delivery systems are employing this triple aim as a means of transforming healthcare. Effective management of population health is key to each of these three elements. So how does care management or care coordination fit into each of these three elements? How do we improve our patient experience? How do we improve population health? How do we decrease costs? We as healthcare providers work in a system that requires continual validation and is evidence-based. That's part of what we have to do with care management. Documentation to support this value is critical. We have to agree on a broad definition, I think, of care management. I'm going to present a definition shortly. I think that most organizations can tailor this just a little bit because we know that we have care management at all levels. We know that there's care managers at the hospital level, there's care managers at the clinic level, and their roles will be just a little bit different, and we have many different types of professionals working in care management. We have a lot of social workers, we have nursing, and even some of medical assistants in clinics do the care coordination. So this is the definition that I'm going to present to you today. This is the 2009 Case Management Society of America definition of care coordination. It's a collaborative process of assessment, planning, facilitation, care coordination, evaluation, and advocacy for options and services to meet an individual and family's comprehensive health needs through communication and available resources to promote quality, cost-effective outcomes, or the triple aim. So you'll notice that there are quite a few steps included in this definition of care coordination. There's the assessment, the planning, the facilitation phase. I'm going to talk about each of these steps and each of these processes a little bit more in the slides to come. And then towards the end, we'll give you examples with Eric's program of how to actually implement each of these stages of care coordination. Okay, the assessment phase. There's lots of different assessment tools that are available out there. I would suggest that you work with a few of the assessment tools. I can tell you that in my own work environment, we have gone through several tools to find one that works well for us and works and meets our needs as an organization. But it does need to be organized. It does need to be systematic. And for us, it really needs to be standardized. We use this to evaluate our patients and all different aspects of their care, including physical, psychological, sociocultural, which is very important, spiritual, cognitive, functional, developmental abilities, and economic issues and lifestyle aspects. So as I go through these slides, I want you all to think about continuous process improvement. And I also want you to recognize that in every slide, in every step of this process, it's definitely a team approach. It's not just one person managing this member, it's an entire team of professionals that manage these folks. So the next phase that we'll move into is the planning phase. This is actually where you develop a written plan of care that is patient-centered, it's evidence-based, and it's interdisciplinary-based after analysis of the data. It's a very collaborative process, and it actually is best if you have your patient engaged in this process with you and establishing some goals, short-term and long-term goals. Make them as best you can SMART goals that they can achieve through this planning process. And finally, you want to obtain approval from the treating physician. I find that I make so much more headway and that I make more progress with my patient if they understand and know that their provider is on board with the plan and the goals that we've developed together. So that approval from the treating physician is critical. The implementation phase. This is your boots on the ground phase. The care management role is critical in the implementation. Care management is the contact for all facilitation of the plan of care. Now, a lot of times what I find is that there's many care managers involved in a patient's care, and I think when that happens, it's essential that you choose one lead care manager to sort of designate and update the plan of care. Also, you want to document all activities involved in that plan of care. You want to organize and Care managers must be cognizant and compliant with standards, regulations, and local, state, federal regulations. And again, documentation, because we are validating this level of care, this care coordination level, we definitely want documentation to do that. Evaluation, one of the final phases. This is how we determine our success in the plan of care that we've implemented. This evaluation, again, it's continual process improvement. As you're moving through the care management process with your member, things are going to change. Their medications are going to change, their needs are going to change. So the continual process improvement is very important in this evaluation phase. If your care plan needs to be updated or modified to help them reach their goals, this is a great time to do that. And again, documentation. And finally, we want to record our outcomes. This is how we determine how successful our plan is. We want to determine, did we reduce emergency room visits? I have one member that I worked with that when I began working had 140 emergency room visits in 1 year, in a 12-month period of time. When we implemented the care management process, we were able to decrease that to less than 40 in a 12-month period of time. So measuring these outcomes by reports and however you can see the work that you're doing and the outcomes of the work that you're doing is very important, very critical part of this process. So roles that care managers play. Well, you can see why we're all so exhausted here. We fill every one of these roles in every one of our patients throughout the entire process of care management. The care coordination team, as I mentioned, it should be interdisciplinary. It should include the patient and their family or whatever supports they have. Something that's interesting that I've included here is the payer. I think that the payer oftentimes is seen as someone you don't really want to be involved in this process, but they can be very helpful in connecting with in-network resources. They can be very helpful in knowing the benefit design of the plan. So I think that including the payer in your care coordination team can be of great great benefit to you as you're implementing this process. So why do we do this? Why do we implement this care management? What's all the fuss about? It's all about patient-centered care. It's the philosophy of inclusion of the patient and the family and care decisions of the patient. And really that makes sense when you think about it. And I know that you all are probably aware and have heard of efforts to increase communication, like in a hospital setting where they'll put whiteboards with information for that patient. It's all about inclusion for your patients. Keeping the patient informed and motivated is key. So we talked a little bit about value and about the value of care management earlier. Care coordination is best described as the ability to influence progression of care. We really don't have the ability to affect length of stay or prescriptions or tests ordered, but we can certainly influence change and influence our members by building care management, trusting relationships with them, and influence change in their life. This influence of care management, the expertise that we have, the education we have, the experience we have, provides a foundation in evidence-based medicine. I wanted to include a slide about disease management. We talked a little bit at the beginning of the presentation about disease management. I think it's certainly an evolving piece of the care management process, and I think that you can definitely implement the same practice protocols that we talked about here with the care management process in your disease management program. Patient engagement. This can sometimes be a bit of a challenge. Sometimes patients aren't really certain they want to change. So how do we engage our members in the care plan that we're establishing, in the goals, in improving their own health? I want to introduce motivational interviewing. Maybe some of you are familiar with motivational interviewing. It's really a form of collaborative conversation to strengthen a person's own motivation and commitment to change. And I will say I've done some training on motivational interviewing, and it can be just a little bit hard to continue a conversation when you're not used to doing motivational interviewing. But it really is about that person, that member, that patient, establishing their own goals. And of course, we all know that if you're going to establish your own goals, you're more willing to work on those goals that you've established than something someone else has told you that you need to do. So motivational interviewing definitely takes on all of the stages of change. It helps you identify as your member in the pre-contemplation, contemplation stage, where they are in that stage of change with that particular goal. Maybe a goal that you've developed or you've talked with them about isn't something that they're very interested in doing right now in their life. So you're probably not going to get great results. And so probably better to use a goal that the member is in maybe the action stage of change, that they're willing to take some action and make some change in doing to improve their own health care.
So this is Eric, and I am excited to be able to share with you how we have worked with children with special health care needs for the last several years in determining the best way to implement care coordination for this unique population of kids. Just as a start, I want to look at the federal definition of what constitutes a child with special health care needs. And bear with me as I read this verbatim, but there are those children who have one or more chronic physical, developmental, behavioral, or emotional, and I'm not going to say those are just one or nothing. It can be inclusionary of all of those. So any of those conditions, and who also require health and related services of a type or amount beyond that required by children generally. As Christine mentioned earlier, we know that 20% of the population uses 80% of the resources, And this group of kids they have a lot of issues, and as such, they use a lot of services, and it requires a great amount of coordination. So we have another survey here which is not going to work, so I want you to just look at the slide for a minute and tell me, as of 2016, or in your mind, look at those choices, what percentage of children in Utah ages 0 through 17 are classified as having a special health care need? And we're trying to see if we can get this survey to activate, but it doesn't look like it's going to do it for us. So let me just tell you what that answer is. It's 16.4%. The National Survey of Children's Health had been administered sporadically over the last probably dozen or so years. The most recent one was from 2009-2010, and at that time, Utah was reported as having roughly 13% of children classified as having a special health care need. Effective 2016 and for each year after that, allegedly, that survey is going to be administered across the nation. So we should have some more real-time information on the population and families and children that identify as having a special health care need a little more frequently than we had in the past. So based off of questions that are asked to families in that survey, there are 5 screener criteria that would classify a child as having special health care needs. So 37, almost 38% of children met at least one of those screener criteria. Interestingly, though, 20% of children met the definition in 4 or 5 screening areas. So that lets you know that we do have some pretty complex kids that we're working with here in Utah and across the nation. So really quickly, those screener questions are looking at the 5 blips down the side there. Does your kid need medicine prescribed by a doctor? Do you use more services than is usual for most children of the same age as your child? Is your child limited in his or her ability to do things that children of the same age could do? Does your child need additional therapies, OT, PT, speech, in addition to the medical services they receive? And then we look at the behavioral health component. Does your child have any sort of emotional, developmental, or behavioral problem for which he or she needs treatment or counseling? So responding affirmatively to any one of those questions classifies your child as having special health care needs. And as I mentioned a moment ago, 20% of kids or families surveyed met 4 or 5 of those criteria. I apologize, this is blipping faster than we would like. There we go. All right, so these are some of the questions that families are asked. We want to know that during the past 12 months, did your family have problems paying for your child's medical or health care bills? And anticipating that we would have a lot of services out there, we would anticipate that probably families and kids with special health care needs would have high medical bills. So if you look at this, roughly 25% of kids with complex needs, so children with special health needs that have complex needs, roughly 25 of those had issues paying for their medical costs. Kids with less complex medical needs, about 17%, as compared with the regular population of that are non-CSHCN, about 11% of those kids had trouble paying their medical bills. This next question, during the past 12 months, how often were you frustrated in your efforts to get services for your child? So keeping in mind these are kids with special health care needs and would be using services of a quantity or type exceeding that of the regular population. How frustrated are you as a family to try to track down the services that would benefit your child? again, as we would anticipate, kids with more complex needs, about 28% were sometimes frustrated, with about 8% usually or almost always frustrated. Those numbers go down. Children with less complex needs at 21% and 1.2% that are usually or always frustrated, which compares the same as the non-CSHCN kids who are usually or always frustrated in efforts to get services. So the next two questions are broken down according to 0 to 11 and then 12 to 17. So the question is, does your child receive care in a well-functioning system? Now keep in mind that that definition is left to families to interpret. So if you think it's not a great system, your answer is probably no. They don't receive it in a well-functioning system. So there's that question for 12 to 17 again. Interestingly, kids 0 to 11 pretty much felt like, was the system functioning well for those kids? For CSHCN, about 26% said yes. Interestingly, though, if you look at 12 to 17, so once those kids hit those troubled teen years, that drops to only 4.2%, feeling that their child receives care in a well-functioning system. So that says to me right there, anecdotally, that parents are frustrated with trying to get services for some of their older kids. This is an interesting question. So when we look at the quantity of service providers involved in a child's care, how many of these families had 9 or more providers, 1 to 2, 3 to 4, as you can see the breakdown there. And do you receive professional help with care coordination efforts for your child? So I don't have the slides up for these, and I apologize, I failed to insert those in. But we know that a lot of the families rely on their own extended family or their families their immediate family to provide the care coordination efforts for their child. The other question is, if you receive help with care coordination, from whom do you receive that help? And when we do this presentation for families, I recently did this for the autism conference at Utah Valley University a couple of months ago, and the majority of families felt that they received the majority of their care coordination from whomever they determined to be their primary care physician or the office that took care of their child's special need. For example, I have a 22-year-old son with type 1 diabetes. When we were not dealing with diabetes, our pediatrician's office was probably that source of primary care for us, who provided the most care coordination. But when we had diabetes issues, it was definitely our endocrinologist. So those roles can change as far as who is kind of the lead on that care coordination piece. Many of you have probably seen this slide out on the internet, but this is a family that posted for their son Charlie the sheer number of programs and people involved in their child's care. Now, the fact that this mom or dad drew this out leads me to believe that these folks are on top of it, and they probably have it just figured out how to make all of these things work. But if you're overwhelmed and it's complex and your capacity is limited to be able to provide care coordination for your child, sometimes it feels like this. It's overwhelming. It's tough, and sometimes it waxes and wanes as life becomes tricky. Sometimes the ability to manage your child's care is very, very difficult. I want to point you to the quote that is here, and this comes from some really smart folks in the Midwest who put together a research piece on care coordination for children with medical complexity. But they say that high-quality services may be individually offered from multiple entities across systems, but integration and coordination of relationships between families and service providers is often lacking. And therein lies the rub. We jokingly in my office, and I shouldn't even say jokingly because it's a reality, but we talk about coordinating the care coordinators. And sometimes it's like herding cats, because these poor families are dragged from pillar to post from a whole bunch of care coordinators. And sometimes when we jump in to help, we don't even realize the number of people involved with helping the family. So we want to make sure that we are not undermining something that maybe someone else has worked diligently for months to help this family. And we also want to get a great inventory to say, if you do have multiple people helping you, what are the limits with what they can help with, and are there still pieces out there that you need services or help, and can we help cover that lack of service that you may be experiencing? We come to the question of why then is it so very difficult to coordinate care? Care coordination professionals are, for lack of better terms, a bunch of do-gooders. They want the best for their patient, and they want their patient and the family to feel that they're getting the best services possible. But so often care coordination is incredibly siloed because of HIPAA regulations, FERPA, so educational requirements. If you're grant funded, you might have federal mandates that allow or don't allow you to provide certain types of services. Other funding requirements, other grants, other monies, other funding streams may prohibit what you can or cannot do. Care coordination takes a huge amount of staff time and multiple staff involvement. If you're a small operation with a couple of nurses and a provider, it might be very difficult to provide really good care coordination. I think there is a lot of fear that offices may disclose something amongst providers that shouldn't be disclosed. Kind of goes back to some of those HIPAA and FERPA pieces, and ultimately fear of lawsuits because of disclosing something or sharing information when your best intent was to try to provide care coordination for the family. I think a lot of times folks get spooked by that, and so that fear keeps sometimes offices from doing what may be best for their patient. We look at 4 defining characteristics in the pediatric realm for care coordination. And just so you know, again, this comes from those smart folks in the Midwest who talk about care coordination. And just so you know, there are no real national standards for care coordination. There are some really great documents out there that outline what care coordination should and could be, but there's no real consensus out there about what it must contain. So given that definition, these 4 are suggestions, if you will, for what care coordination should contain. Family-centeredness, as Christine spoke earlier, it's very important to include the family. If the family does not have buy-in and doesn't feel like they contributed to the care coordination plan, you're spinning your wheels most of the time. Families have to feel connected and have to feel that they are contributing to their own solutions. It has to be a planned, proactive, and comprehensive focus, so we look at multiple areas. Ultimately, we want families to be empowered to act for themselves. So we want them to develop skill set throughout the process that allows them to advocate for their child and seek and find and connect and obtain the services that would be beneficial to their child. And then the last one here is that emphasis on cross-organizational relationships. I think sometimes within a care system, and I don't want to overly simplify it by saying this, but let's look at Christine's system where it might be all university providers. That may ease that communication process a little bit. I'm not going to say it's a cakewalk because there are still challenges there as well. But sometimes it's easier within a large system where all the components are part of that system than when you're dealing with multiple different entities, some of which are governmental entities, healthcare entities, educational entities, to be able to make those cross-organizational relationships happen and that communication happen. I'm not going to read through all of these. I just want to share those with you, but there are 10 principles for a shared plan of care. And I put in quotes here that this is the ideal. So this is when all of the stars align and your lucky number came up and everything's just great, that all of these things can happen within a shared plan of care. Unfortunately, life is a little messy, and dealing between organizations sometimes can be cumbersome. So take in mind that if everything were perfect and we could run this in a parallel reality, these 10 principles would be easily done. But again, we want families to be actively engaged, the communication among the medical home team, and medical home is that place where you receive your usual and customary care. So quite often your primary care physician's office, as I mentioned earlier, maybe your main specialist for whatever disease or issue you're working with. Providers and team members don't just have a knee-jerk reaction. They are looking and weighing all of the evidence that's out there. The families have built, or the providers, let's put it that way, have built relationships with those families. So they've developed relationships of trust that allows the families to say, we have confidence in our care team, and we have confidence in our care coordinators, and we know that the information and the suggestions they provide to us are based on sound evidence. And we want family-centered teams to be able to have access to that information and to be able to share data amongst various providers in those care plans. We look at shared goals. We monitor progress. These are some things Christine mentioned earlier. We prepare and plan for all transitions. A big transition for us is when kids are kind of teetering on the brink of 18, and all of a sudden they're not a cute little toddler anymore, but they still have the same sort of needs, healthcare needs or behavioral health needs that toddler did. All of a sudden at 18, they get thrown to the wolves just a little bit. So that is a big one that we look at. Transition can be from preschool to regular school. It can be from elementary to junior high to high school. Anything that is a big life change or a shakeup, we want to be able to anticipate those and help families to really prepare for how that impacts previous decisions they've made and decisions they may be making in their immediate future to ensure comprehensive care for their child. We look at a care plan, and we say it's a common shared document. That in and of itself can be problematic. We'll talk about that in a minute. And ultimately, care is subsequently well coordinated across all involved systems. Again, possibly easier when everyone is part of the same organization. Definitely more challenging when everyone wears a different nameplate for their organization. Christine talked about using multiple different tools and kind of trying stuff on for size and seeing what works to help you do an intake, to help you coordinate care for the family, maybe a tickler that is some sort of a reminder to cover all the bases with families. Sometimes some of these questions are just yes, no. Do you have concerns about this? Do you have concerns about that? This is a document that was put together through a Health Resources and Services Administration, HRSA grant that came into the state for 3 years, looking at care coordination for children with special health care needs. And a multi-agency team put this document together to kind of look at multiple pieces. And it's probably tough to read that, and when you get the slide deck, you can expand that out and take a peek at that document. And we'd be happy to share that with anybody because it's definitely modifiable to meet your organization's needs. But these are the pieces we're looking at. Patient information, what is the main concern? Who is your primary care physician? What medications are you on? What are your top 3 concerns? You know, the elephant walks in the room. Let's take the top 3 bites out of that elephant and try to hone it down. What's your biggest concern as a family? And that may or may not be the concern that you were referred to care coordination for from your primary care physician. So we look at those social and family dynamics. What are the family's strengths? What are they good at? What do you feel your child is good at? What makes you cohesive as a family? What are the current services and specialists you're receiving? If you reflect back to that big chart with all of those services that Charlie was receiving, that can be huge. What do you need assistance with? And some practical things like, do you use durable medical equipment, and do we need to help you track that down? So we sit with the family, we create a care plan. We want them to have that be accessible. That document is only as good as it is accessible to the providers and the other service folks who are working with that family. So we have, through our electronic medical record, a patient portal, and we can store that care plan in that patient portal so families have access to that electronically. If you are a tech person, sometimes it's nice to have that electronic piece. If you are not, sometimes there is great comfort in, can't get that slide to advance, sorry, in creating what is called a care notebook. It's a 3-ring binder. It's divvied up into multiple sections. It can be complex. My team is willing to sit with families and help them organize their 6 inches of paper that they have from all the providers that they're seeing. But that care notebook can be hauled from provider to provider with all the current information on top so that they can get a good picture of what is going on in all the services with which the family is involved. This is just a picture from the care notebook. You'll notice the Utah Family Voices page is on here, and they have pulled together a bunch of information that's used across the nation to help create these care notebooks. So there's some really nice organizational pieces there. So the question is, where can you find care coordination? And I think families sometimes feel like they're just out in the wild all on their own and there's no one really there to help. But there are so many places and so many people who are willing to help. First question is, where's your primary care physician's office? Who helps you provide that usual and customary care for your child? Find out their capacity within that office, what they can do. Again, if you're with a small organization, maybe out in rural Utah, you might not have huge care coordination possibilities there. What if you're inpatient? While you're there, who's helping you organize and know what needs to happen while you are in that hospital stay? It's always scary at discharge because you're going home and you don't have that whole team sitting there at your beck and call. So what sort of services are offered at discharge? Is social work involved? Is there a care coordinator involved who says, reach out to me after you go home so we can help you sort out all of these discharge instructions we've given you and get you into those specialists to which we've referred you? Again, is that sort of care maybe offered through your primary care physician's office? Do you see a specialist? As I said, in my case with our son, our endocrinologist was kind of our care coordinator a lot of times when we were dealing with diabetes issues. Do you receive or have a behavioral health benefit? If you do and you're receiving behavioral health services, is there a care manager or a care coordinator through that organization that can work with your family? What about school? Does school help to coordinate services for you? Do they help you create that individualized education plan or help work with your 504 medical plan for your child? Do they offer additional services there? And then the insurance company. Christy mentioned before the payer, and for me, even working in healthcare all these years, sometimes I'm terrified of my insurance provider, and there is no reason to be. These folks want to help, and so it's important to go to your insurance provider and say, how can you help me manage this system, make sure I stay within my policy allowance, and how can you help me to track down those services that would be beneficial? And then additionally, what outside agencies can offer help? So I mentioned a minute ago the Utah Family Voices. This is a peer-to-peer network of parents of kids with special health care needs who have not just talked the talk, but they have lived the life and they know all the ins and outs of how to work with organizations and what are good strategies to help families get services. So they are an amazing resource in the community. Here's my program, and I'll ask you to pay no attention to the guy in the red sweater because that's a terrible picture. But our integrated services program through the Utah Department of Health is able to help kids from birth through young adulthood, and I'm saying that in air quotes because young adulthood is kind of a loose term, but we are able to help families connect with services that they need. We are funded through the Maternal Child Health Block Grant that comes into the state, and because of that, we have a lot of latitude with services we can help families connect with. We're not just medical, but we help families with social services and all sorts of things. So through our program, we have a referral. We receive a referral. We do an extensive intake, like you saw that paper I showed you a few minutes ago. We work really hard to discern those families' needs and what their concerns are. Then we try to connect families with the support services and specialists from which they may benefit. We work to create that shared plan of care, so whether it's electronic or in a notebook. We follow up with the families. We continually monitor those needs that the families have and make modifications where necessary. We try to help families prepare and make that transition to adulthood, including adult medical care. And then ultimately, we support the medical home concept, which is supporting the primary care offices who may have lack of capacity to really provide comprehensive care coordination to the families they serve. So I wanted to share a really quick success story. Heather Carlson is one of our care coordinators based out of our Ogden office, but she worked with a mom named Lori who had left a violent relationship out of state. She and her son, who has severe autism, moved to Utah, and she was incredibly overwhelmed after they fled life in Colorado. Not sure where to go, not sure what to do. She'd been given a lot of advice, but just didn't really know how to put everything together to make it happen sequentially so it made sense for her family. She somehow was connected to Heather. Heather sat down with mom, helped mom prioritize what their biggest needs were, worked through those initial needs, got the son on DSPD services, so the Division of Services for People with Disabilities, that provides all sort of supportive services, got Medicaid going for the family, got him onto supplemental security income, so SSI through the Social Security Administration, worked with the schools to make sure he was in an appropriate school, and they got an IEP and 504 plan in place for the family, got some ABA, so services for kids who have autism spectrum disorders, got some of those behavioral management services in place, and this has taken months to happen. But ultimately, mom felt so well supported that she felt like she could go back to school herself. And last thing we heard, she was working on getting her degree in social work. So helping sort out chaos and making life a little bit, hopefully, easier is part of what we try to do through our program. We've listed some helpful websites. The Medical Home Portal is an incredible site done through the Department of General Pediatrics through the University of Utah. Helpful resources, diagnostic information, support, care planning, resource guide for families. I mentioned previously the Division of Services for People with Disabilities. And then obviously Medicaid is a big player in all of this to provide medical care for kids who may qualify. The Supplemental Security Income Group through Social Security Administration. The Utah Parent Center, an amazing group here in town that works with families and provides incredible educational opportunities to help families develop skills, to empower them to take care of their kids with special needs. Previously mentioned Utah Family Voices, and then another amazing group, the Help Me Grow group, that provides ongoing monitoring for kids who may not yet or may never be classified as a child with special health care needs, but helps to do some ongoing monitoring and progress to make sure that kids are developing appropriately, and if not, making referral for additional services. Some of the survey information I mentioned previously on the National Survey of Children's Health is available, and this is the website, and it's interesting to be able to log on and look at that information. So that is available to anyone who would like to go in and look at national statistics or Utah statistics. And this fall, somewhere around September, we should have 2017 data in there so you can do a comparison between 2016 and 2017. Some of what I mentioned today was a standard from the Lucille Packard Foundation, and there are really amazingly put together guidelines for how to create plans of care and what should be included in care coordination for kids with special health care needs, but it also transcends to other populations, youth and adult populations as well, and would be easily modifiable. So this is a great link for anyone who's looking at providing care coordination. Here's our contact information for my program. If you're dealing with kids with special health care needs or think they may be at risk for special health care needs, please contact us. We're happy to get folks into services and try to help them track down services that may be applicable to them. And then lastly, we have put together a work group in the state from multiple organizations over several years, put together an introduction to care coordination. We kind of smilingly say it's a primer for folks who want to provide care coordination but might not know the when, where, why, and how to do that. And so this document is in just a really nice user-friendly format. It's easy to read. It debunks a lot of myths out there on why you couldn't or shouldn't provide care coordination. I think it provides a lot of guidelines and resources for people who are considering providing care coordination for their populations. And it's not just based off of kids. It is for the entire population who could benefit from care coordination. And with that, we'll turn it over and see if there are any questions that have come in. And if you do have a question, now is a great time to submit that as well.
As a reminder, to submit questions, please use the chat function in your WebEx screen.
We'll give that just a minute to see if we get some questions come out. So we do have a question here from Don. Will we please send this out to you via email? And everyone who registered for this will get the slides and the link to the recording as well. So yes, that will come out to you once we finish the webinar today. We'll go ahead and hang tight just another minute, see if we have any additional questions.
It doesn't look like any further questions are coming in. We will keep the presentation running for just a little bit longer in case anyone thinks of anything. But for the rest of you, thank you very much for joining us, and please enjoy the rest of your day.